Welcome to the session. In this session, our esteemed speakers will share how you can leverage the cloud and actionable data, elevating the power of social determinants of health to go beyond the zip code and improve the health of communities with precise, data-driven strategies. Before we dive in, we'd like to thank the sponsor of this session, Amazon Web Services. Amazon Web Services is the trusted technology and innovation partner to the global healthcare and life sciences industry, providing unmatched reliability, security, and data privacy. This session will be moderated by Alex Kane, the lead of business development and strategic outreach of nonprofit healthcare for Amazon Web Services. Alex, the floor is yours.
Great, thank you so much. Hello, everyone. I'm thrilled to be leading this panel of innovators today around such a critical topic as we look to bring precision to social determinants of health and close the health equity gap to improve patient care. And now I'll introduce our panel of experts. Dr. Dan Lowe brings over 20 years of clinical experience as the Chief Medical Officer of Adaptix, a cloud-based platform that enables frontline clinicians and clinical leaders to leverage EMR data to quickly monitor, evaluate, and adapt care across patients, treatments, teams, and workflows to improve quality, equity, and efficiency. He is also an attending pediatric anesthesiologist at Seattle Children's Hospital and an associate professor of anesthesiology at the University of Washington. Dr. Michael Cooey is an internal medicine physician and associate chief medical informatics officer at Rush University Medical Center. He is also the program director for the Clinical Informatics Fellowship at Rush. He is the project director for the Health Equity Care and Analytics Platform project. This project addresses health equity by combining machine learning and predictive analytics to risk stratify and proactively engage patients. Dr. Angela Shippey is Amazon Web Services Senior Physician Executive and Clinical Innovation Lead for Nonprofit Healthcare. Previously, Dr. Shippey served as Senior Vice President, Chief Medical and Quality Officer at Memorial Hermann Health. Prior to Memorial Hermann, Dr. Shippey served as Chief Medical Officer of HCA's Gulf Coast Division and as Vice President of Medical Affairs at St. Luke's Episcopal Hospital in the Texas Medical Center, where she practiced as a hospitalist. And finally, Kat Esser is a strategic planning and innovation executive on the AWS nonprofit healthcare team, bringing over 2 decades of leading global strategic innovation engagements across public and private sector industries with 19 years in healthcare. Prior to joining AWS, Kat served in leadership roles across organizations including Kaiser Permanente, Anthem, Humana, Pfizer, CVS Health, Veterans Affairs, Military Health System, the CDC, Health and Human Services, and CMS. So as you can see, we have a rock star panel today, and we're excited to jump in. So let's dive in first with a question for Dr. Shippey. Dr. Shippey, you've said that health equity is the new quality and safety in healthcare. Can you elaborate on this evolution and talk about some of the key outcomes and metrics driving this shift?
Wow, I love that question, and thank you for allowing me to kick off the panel with this perspective. So the concept that health equity is the new quality and patient safety was introduced to me by a colleague who later published an article in The Catalyst. And as a former chief medical and quality officer, that concept and comparison really resonated with me. If you recall, in the early days of quality, first we had to admit there was a problem, and then understand those opportunities for improvement, embrace a systems approach, understand improvement science, train staff, utilize performance improvement methodology, and deploy tactics for continuing process improvement. And that was all based on event analysis and the common causes that were determined and discovered during those analyses. When you look at how all of that data came together, you can see how that same approach can be done with social determinants of health. So the World Health Organization defines health equity as achieving full potential and well-being. To achieve full potential, you have to understand the social determinants of health. to better understand and target social determinants and how they impact health outcomes and quality of health, then you have to understand all the disparate sources of data. You have to allow them to come together and provide the information that enables insights that actually allow you to target communities and what they need. So I think as healthcare providers and others are continuing on a journey of better understanding communities and their social determinants of health, this is a model that can be used, and it is a way in which data can be used and brought together to actually allow those targeted interventions.
Thank you, Angela. And a great point there about bringing together data and specifically actionable data. And Kat, that kind of leads us into the next question here. Question for you. Kat, you've supported organizations in the past on their social determinants and health equity journeys, and you're currently working with health to leverage the cloud actionable data to bring precision to their SDOH and health equity strategy and innovation initiatives. Can you talk a little bit about what these strategies and innovations look like in practice and how they drive personalized care with precision?
Yeah, great question. And so nice to be here with everyone on the panel today. First of all, this is going to be really exciting. And to kind of build on what Dr. Shippey was just mentioning, you know, every healthcare organization is at a very different place in its social determinants of health journey. And some of the really exciting things that we're seeing and able to help with today around strategy and innovation in that space is really starting with this recognition that the EHR is only one data point and it's dominated by clinical data. But to get to that whole health, right, that true whole health picture of your population, we're seeing healthcare organizations really lean in and say, you know what, we need to start integrating social determinants of health and other social data streams into that big picture. It's really hard, but we have the honor of basically seeing how, you know, by reaching out and looking across kind of that clinical perspective that they've had is really where the interesting kind of social needs, social vulnerabilities are able to emerge. And then they're able to use that data to then personalize the way that they're delivering care and services, not only from a clinical perspective, but also from a social perspective to their patient populations. And then it goes beyond even further for some of those organizations that are more mature and using data to really personalize, and they're actually extending beyond their clinical walls into the communities. And I think that's the third kind of piece or leg of this stool. It's the clinical, it's the social, and then how does the community also play a role where you can really pick up from people where they live, work, learn, play, pray around those social pieces of data that you're probably not going to get in the electronic health record. And the way we see that actually manifesting back to benefit the patients is starting way upstream with screening. So not just screening for clinical risk factors, but screening for social vulnerability and social needs factors. And then turning those screenings into who in our population is actually at risk for food, for housing, transportation. We've seen organizations even take it to the education and employment level with their populations. And then really turning that so that the providers can then use that information and say, you know, for my food as medicine program, I'm going to actually give a prescription for food and refer you out into our community-based partner to help you take care of that piece. So we're really seeing how organizations are able to pull from different social data sources, and not just social determinants of health, which I know the WHO right now talks about 10 of the big ones, really going beyond that and saying, you know, do they have broadband access? What is their level of literacy? And all of this data is readily available to use and integrate back into their system.
Thank you so much, Kat. And I think your answer dovetails really nicely into my next question for you, Dr. Lowe, because I know Adaptix uses all all sorts of this kind of information in the work that you do. Dr. Lowe, Adaptix has leveraged the cloud, advanced analytics, and AI/ML to create personalized strategies for addressing health inequity at the source. Can you talk about how the cloud is giving clinicians equitable access to data and allowing them to quickly get answers that close gaps in health equity by providing precise insights around social determinants of health?
Yeah. There's a lot to unpack there. Thank you for the question. It's a privilege and an honor to be presenting alongside these esteemed panelists. So, let's dive into the first bit. Like, how does the cloud help clinicians get access to the data? Like, this is probably the number one problem facing clinicians. Like, if you just open any newspaper that talks about medicine and healthcare right now, burnout is right at the top of the list, right? EMR is the culprit, and so there's too many clicks, there's too many people. Like, I'm in front of a computer all the time, I'm entering data all the time, I'm not seeing patients. That's a resounding theme, right? And the insult added to injury is once I enter the data in, I can't get it out. So let's just start with getting the data out. And that is a hard problem for many hospitals, most hospitals in the United States right now, because of the way they architected how they store their data, right? So now the cloud changes everything because, so we partnered with AWS and you guys have been an awesome partner. Our solution is hosted on your platform. And what we're seeing is now, instead of waiting literally 6 to 12 months to get access to their data, via Adaptix, powered by AWS, they can get frontline clinicians can get their data inside 1 minute. You've turned a 6-month process into a 1-minute process, and that changes everything. So now, bring it to the second half of your question is, well, if they can do that, so what? What have they done to reduce disparities and inequities in healthcare? I've got 2 stories that I want to share with you that just hit my desk in the last couple of weeks. One is from a children's hospital, one is from a labor and delivery suite. So they're kind of related, but not. The first one was a children's hospital, and they ran Adaptix to their system. And one of the tools within our system is we have an equity AI layer that scans your entire system for racial, language, gender disparities in either the process of care or outcomes of care. So it basically crunches vast amounts of data, something that would take years for a whole team of analysts and it does it in a couple of minutes because you guys provide us a supercomputer basically to do that. So it's amazing. The thing they surfaced right up was certain patient groups, Black patients and Asian patients in this hospital had a 3 or 4x higher 30-day reoperation rate for any surgery, and that was unknown to the whole staff of the hospital. And so the next thing they did, it was actually an otolaryngologist says, wait, if Black patients have a 3.5x higher reoperation rate, does that happen in my segment of the house? And he was able to ask that same question just for otolaryngology patients. And the answer was, yes, we're seeing the same pattern. And he goes, I've been here 10 years. I didn't know that. Because how would you know? Most clinicians are too close to the work to see the forest from the trees. If you have a 3% admission rate rather than a 0.9% admission rate, and there's 20 of you, how would you ever figure that out? You just don't, you can't see it unless you actually have these analytic abilities. And so he asked the second question, which was like, well, if it happens in otolaryngology, does it happen with the most common thing we do? I know the most common surgery we do is a tonsillectomy, 1,200 of those operations a year. So he looked at that with Adaptix and said, wow, we have the same problem. We have a 30-day reoperation rate for Black patients and Asian patients, which is 3.5 times higher than for non-Hispanic white patients. I didn't know that, and neither did any of the staff. So then they were able to do something about it. They shared the data. So there's data transparency now. They share the data of their team. Said, did you guys know this? And look at this gap. And the next question was, what ideas do you have to close that gap? And they asked it was the nurses who figured it out. The nurses said, well, hang on, they're not coming back on day 1, they're coming back on day 3 or 4. So that means something is about wrong with how we're teaching the education piece as they leave the door. It turns out for the Asian patients, the instruction, well, actually for everybody, the instructions were only available in English. The app was only available in English for post-op teaching. The instructions were written very much targeted, not specifically for different racial or language groups, but it's very generic for non-Hispanic, white, English-speaking families. So they'll say, hey, after your tonsillectomy, drink 3 bottles of Gatorade every day because that will keep you hydrated. The Vietnamese patients didn't understand what that was. You can't buy Gatorade at the Vietnamese store, right? So it was things like that which uncovered. And so the nurses said, well, let's change how we teach. Let's come up with an infographic that just has the number of cups you're supposed to drink, and you can just cross it off. So if someone else is caring for your patient, your child, when they go home, grandma or grandpa who's looking after the kid can understand that. And so it came down to diagnosing the problem with their own data, fixing the problem. 18 months later, they've made progress. There hasn't been a single Vietnamese patient who's had a bleed. There hasn't been a single Somali-speaking patient who's had a bleed. They were able to fix the problem with their own data. So incredible story, because that's a life-threatening complication. The second story that came across my desk, entirely different hospital system, was looking at obstetrics. Again, they ran their entire, they've been on an EMR for about 3 years. And yes, the EMR is not the sole source of data, but it's a very rich source of data if you know how to tap into it. They looked at their entire L&D data, and that comprises pre-pregnancy, what happens during your pregnancy, what happens during your birth and afterwards. And they found, so they ran it through and they said, look, why is there a pain disparity? Why is there, if you have a cesarean section in this hospital, why do specifically Black women complain of a 1.5 higher pain score than everybody else? What's up with that? And they were able to surface a disparity in the outcome of care. They were able to dig down to say, well, how often the pain assessment's been done, how many doses of oxycodone you get. They were able to dive right down into the operational data and go, well, what is it that we're doing differently? And again, solicit input from their staff, and they're beginning to close that gap as well. But the key thing is, unlike Dr. Shippey was talking about, go back 10 years when we're just figuring out improvement science, right? Do something, right? Get your baseline, do something. Well, what's the next bit? Complete the cycle. Does the thing you did move the needle? And that piece was hard, right? That was you might do something for 6 months. How do I know if it's worked? Well, with modern technology and the cloud and modern EMR, within a week, a month, 2 months, you get that immediate, am I moving the needle? In the years gone by, we had to wait. You had to take a leap of faith, right? Remember, you have to go do something, and in 2 years, we'll look back and see if it works. You don't have to do that anymore. So our ability to learn and adapt our systems is in a really exciting place right now. So that's a very long answer to a very short question. But
thank you so much, Dr. Lowe. I think what a fantastic example of not just data, but really that actionable data, right? Yeah. Giving clinicians the power to take action on what they're learning from those cloud-driven insights and getting really precise with their interventions, customized to their specific patient population. So thank you for that. Sort of in a similar vein, Kui, this is the question for you. Rush University Medical Center is also transforming the way it leverages social determinants of health, taking an equity lens to data to provide patient care. Specifically during the early days of COVID, in partnership with the Chicago Department of Public Health, Rush created a cloud-based public health analytics hub. And this hub aggregates, combines, and analyzes multi-hospital data related to patient admissions, discharges and transfers, electronic lab reporting, hospital capacity, and clinical care documents of COVID patients receiving care in and across Chicago hospitals. Can you speak to how COVID changed your analytics strategy and how the cloud played a role in this initiative?
Absolutely. Thank you for the question. And I definitely echo what all the other panelists have said. I mean, this is really kind of an exciting time for health equity, for analytics, for precision medicine in general, because I think we have a lot of the tools now, and we definitely have kind of a changed context, and COVID kind of helped with that. Yes, COVID was, a terrible thing, but it definitely helped surface a lot of things that otherwise wouldn't have been able to be possible. So COVID really did kind of three things that I'll kind of share. First, it kind of changed the context of the conversation. It changed the speed at which we needed to deploy, and it also changed the scale. Now just individual hospitals doing things is not going to be sufficient. So the context changed because now we all had a common goal, not just my hospital on the west side of Chicago, the north side Chicago hospital, the center, south side, we all had the same common goal. And not only that, not only were the hospitals aligned, the government was aligned, insurance was aligned, population was aligned. Everybody was aligned and laser focused. So we could do these types of transformational collaborative work that otherwise wouldn't have been possible. So the Chicago Public Health kind of ordinance mandated reporting of the structured data. Awesome. Now there's a government mandate. So all the hospitals are like, great, let's kind of work together on this. And now we could just focus on the solution. Now it wasn't, a technology searching for a problem. Now it was a technology that had the ability to kind of address an issue. And COVID changed the speed at which we needed to do things and deploy. You can't wait years for this type of collaboration to kind of come into place, for these analytical systems to kind of work, for all of these different EHRs to kind of all of a sudden magically aggregate all of their data. You needed a common way of bringing in all the information, and that's how the cloud kind of really helped there. And the third piece was the scale. You might be able to have pockets of innovation or pockets of development from each and every one of these hospitals or centers or municipalities or even governments, but you needed everyone to work together. The solution we wanted to know was, what does the bed capacity look like in Chicago? Do we need to spin up some of these other types of McCormick Center, which is a facility to kind of house some of these other patients? Like, do we need to do that for the city where we're the kind of hotspots? One hospital is not able to do all of these things. And so the cloud played a huge role in allowing that to happen. The cloud is not new. Other industries have been using this for years, but the cloud during COVID is really kind of the only solution that can allow us to achieve our end goal. And the things that the cloud did was it allowed us to build a flexible system that was easily built, scaled, and shared. So I just want to kind of repeat that. It allowed us to build a flexible system. It was easily built, easy to scale, and easy to share. And without either one of these, the whole entire project would have failed, because we don't know what are all the new systems that we need to incorporate. We don't know how COVID is going to react in the future. So it had to be flexible. We had to build a system using kind of common tools that could integrate from other different data sources. It had to be easily built because we didn't have that much time and we only had limited resources. And it had to be scaled because it wasn't just one hospital, it was all of the hospital kind of in a surrounding area. And it had to be shared. If we do something in one hospital, it has to be easily ported to another, because otherwise you're reinventing the wheel over and over. And when you have data siloed, it doesn't hit populations the same. It really disproportionately impacts populations that have a hard time navigating on their own. And so that in and of itself, siloing data, it factors into some of the health disparities that we see. So really, it has kind of completely transformed the way we think about analytics, and COVID has allowed a lot of things to happen much sooner than we did. But I really can't stress enough the fact that it was flexible, it was easy for us to build, easy for us to scale, and easy for us to share. Really were a game changer.
Fantastic. Thank you so much. And this leads nicely into our next question, Kat. Dr. Cooey just touched heavily on the benefits of the cloud and his team's work. Kat, in your work with healthcare organizations, you have helped them leverage the cloud and actionable data to, quote unquote, go beyond the zip code. Can you help our audience understand what going beyond the zip code means, and how actionable data and the cloud play a role to make that possible?
Yeah. So this one's really kind of threefold, I would say, in the most simple terms. It's really going beyond the zip code, going beyond stereotypes of underserved populations, and then going beyond even social determinants of health and what that means. And so I think, early on in my time that I had the honor to help different organizations, I realized I was carrying around this pretty big stereotype that an underserved population were folks that were in lower socioeconomic brackets. They had no car. They didn't have an education. And what I realized pretty quickly is that there are many underserved and unserved populations that do have a education, they do have a car, but because they don't show up on a zip code, they're not really getting served. And some of these populations looked like American Indians that lived on reservations. Some of them looked like the LGBTQ community for a very large integrated health system that I worked with. Some of them looked like new moms. And so I think going beyond the zip code really helps you target those that have an address, right, or that are tied to an address, but it really leaves out some other populations like those that are transient or those that are in very, very rural areas. And so data has really allowed these organizations to start to think about going beyond the zip code and going into a different level of information around their patient populations, because they were really only seeing part of their patient population by zip code. So learning how to screen patients with some of those questions that we're all bringing up together, I think, in different ways, right? Do you have a cell phone? Are you connected to a social network? What are other ways that underserved and unserved populations can start to be identified so that they can actually even have a chance to get care? Because it's one thing to get care when you're getting noticed, but if you're not even getting noticed, then it's almost impossible to get care. So I think by starting to look at how different data sources that actually go beyond the clinical walls, as we're all talking about, how can you actually start to pull that together? And we see organizations really targeting and opening their aperture around kind of dropping these stereotypes around who are underserved and unserved populations. And then the third piece is really that fine nuance between thinking about social determinants of health, which are really kind of give that association that your social conditions or the social factors are going to determine your health fate and there's nothing you can do about them, versus going towards more social drivers of health, where different communities that we're working with and different health systems are actually saying, no, how can we together overcome some of those social factors for underserved and unserved populations and really make sure that they're able to change their social conditions and not just get determined by them. So I think it's really kind of those three things all put together. It's not just a zip code. There's still, I think, some stereotypes that we think about around underserved. And I know I had a big eye-opening lesson with that. And then how do we think about social drivers of health where communities and health systems can actually help their populations overcome some of those conditions that may not be adding to their good health outcomes.
Thank you so much, Kat. And so you're really hitting on bringing together different data sources and keying into different types of social drivers of health to get more precise in how we're identifying underserved populations. And something I want to ask you, Dr. Shippey, is about, as we do identify these populations with precision, and as organizations go beyond the zip code, how do we get more precise in our outreach to these individuals leveraging the cloud?
I mean, I've just heard great examples from both Dr. Cooey and Dr. Lowe on how targeted information really helped identify where we needed to go in particular communities. And so when I think about outreach that's based on the needs of a community, I'm thinking about how do you spin up resources in the cloud that help you build a solution. So we just heard about how a language barrier made a difference. Being culturally sensitive made a difference. Understanding individual needs in a community helped target where to put COVID resources. And so we really do have to understand those non-medical determinants or social determinants of health when we look at interventions. So if you think about if transportation or employment hinders a traditional in-person visit, then we want to support those platforms that allow for virtual care or for home monitoring. If you think about patients who need a little bit more health literacy or they're trying to manage chronic disease, then being able to come in contact with technology, with a chat bot that allows them to have a direct connection to an educator or an appointment or more information. That's the kind of targeted information and intervention that needs to happen in these communities that we're serving. And we just heard really good examples of that. I agree that during COVID, we learned so much. And I remember phenomenal stories from across this country about how targeted interventions were made. And some examples of that, and Dr. Cooey also alluded to it, understanding a community so well that you knew if they were multi-generational households, understanding the language that was spoken, understanding if the intervention needed was they needed PPE, but was it gloves or was it masks that they needed? They needed care. Was it acute care? Was it chronic illness? Was it for COVID itself? Did they need testing or did they need vaccine? Did they need a ride? Did they need a ride and an appointment for monoclonal antibodies as an infusion center when that became available? That's the level of detail that it will take to understand a community, those non-medical factors. And that's the kind of data that will be needed to be able to have that precise intervention. And that's what I'm really looking forward to, being able to make a difference in these communities.
And Dr. Shippey, can you talk a little bit about how exactly the cloud supports that type of work?
Well, I think you've heard some really good examples of how it does that. Being able to have assets in the cloud allows you to bring them up very quickly. Dr. Cooey talked about scale. Dr. Lowe talked about being able to put this data right in the hands of those frontline caregivers. So as those that are laying hands on patients can tell you where those opportunities are for improvement and whether or not they're working with the patients. So those are really good examples of how when you have resources that are available to you in the cloud, you can build those solutions that allow you to have that type of impact.
Fantastic. Thank you so much. Dr. Cooey, next question is for you. Can you speak to Rush's cloud and analytics strategy going forward as it relates to social determinants of health? So what have you learned from the COVID Analytics Hub, and how are you to other areas of care in the future?
Absolutely. And so probably the biggest thing that we learned from the COVID Analytics Hub in that it pertains to our analytics strategy is kind of the cat's out of the bag. It's possible to do these types of work. It's possible to aggregate the patient information. It's possible to get different information from different sources. And it's possible to do this at a much faster clip than what we were expecting to, which is news to me, and it's great for music for my ears because I'm an impatient person by nature, kind of want everything yesterday. And so now, our cycle times are just so much shorter. Not quite as good as what Dr. Lowe is saying, getting something within a day or a minute. You're still taking longer time, but it's not taking quite as long. So the context of this has changed now. Now we know we can share data, we can move quickly, we can do kind of a huge impact, and we're kind of replicating the same process that we went through with the Analytics Hub to some of our other projects. The second thing is that, speed is even more paramount now. And so on the west side of Chicago, there's a life expectancy gap of 12 years initially. So in more affluent areas, patients were surviving 12 years more than patients in less affluent areas. And now after COVID, that gap has actually extended to 16 years. So things are going backwards. And so now that there is kind of a burning platform for us to say, look, we need to make moves, we need to make decisions, we need to kind of get help to these communities that are needed. And I won't go into kind of the full story of this patient, but I had a patient very early on in my career who worked in the prison system as a counselor. So a very important job, helping a lot of people. The patient was only 38 years old, and I just could not get the patient's blood pressure and diabetes under control. I told the patient to come back every month. They wouldn't see me for 4 to 5 months. And then less than a year later, the patient unfortunately passed away from a cardiac event. It could have been preventable. And I just think that, we were treating him the same as my patients who were kind of in different situations and scenarios. And so now the projects that we're working on are pulling in multiple different sources in multiple different ways. And so that really kind of gets at the flexibility of the cloud. I'm getting data from our EHR, I'm getting patient-generated data from their home. I'm mass surveying our patients at scale for social determinants of health. These are things that every healthcare system is doing, but traditionally we're doing it with medical assistants, community healthcare workers. You just can't screen enough patients. There's just not enough manpower. So the flexibility of pulling in data from those places, it was easy to kind of build some of these tools. So the survey tool that we're built, our database is housed in the cloud. Vendors can connect to it with open APIs. Makes it very easy to kind of build out some of these tools that we need. And then I had already kind of talked about the scale. This type of infrastructure and architecture really gets at getting data in from multiple different data sources. We make sure our patients are involved in kind of developing some of these tools. Once we have the data in, we use some of the cloud tools to run analytics on the data, which patients are at highest risk, which patients are at lowest risk, and those that are at highest risk get different interventions than those at lower risk. And then this is all shareable because we use similar tools and we can share to some of our colleagues. And so kind of a rising tide lifts all ships. We're hoping that as Rush kind of goes through this exercise and this work, we're able to share that with others. And so we're focused right now on social determinants of health screening and high blood pressure. Our next one might be diabetes, cardiac events, strokes. I mean, the same process could just be replicated over and over and over again as we slowly start to address social determinants of health and these medical conditions in all of our patients.
Fantastic. Thank you so much. Dr. Lowe, Adaptix specifically gives clinicians actionable data at the point of care to leverage social determinants of health and close gaps in care. Can you speak to how this data empowers clinicians specifically and allows them to get more precise in their care of patients?
Yeah, let me try and tie all the stories we just heard, the COVID, the increased shorter attack times that Dr. Cui talked about, and the improvement science that Dr. Shippey talked about, and tie that all together with my answer. So COVID did a number on everybody's vascular system. So we were seeing across all the communities a massive spike in strokes coming through our EDs. You saw it in Chicago, we saw it in Seattle, we saw it everywhere. One of our hospitals, a level 1 trauma center, had just installed Adaptix at a year into COVID. And there's a clinician, the medical director, on her first day of turning the system on, goes, well, let's look at our stroke care. We're getting 20 of these patients a day right now. Let's look at that. And for stroke care, one of the key performance indicators is from the minute you enter the door to the minute you get your TPA into your arm. And let's look at that. And she looked at her data over the last 18 months, and she found it was about 32 minutes. And that's great. That's slightly better than the national average. She didn't stop there. She goes, does it matter what you look like when you come in? Does it matter what language you speak? Does it matter what gender you are? And when she stratified it by race, she found that her Black patients specifically were taking 49 minutes, so almost 20 minutes longer to get the same care for the same disease, for the same condition. So a patient comes in, they can't speak and they're drooling, and if you're Black, it takes 20 minutes longer to get your TPA. What she did with this information is interesting. She took it to her leadership group, and in the meeting that week, they go, well, let's break this down. Let's look at our processes. How long does it take if you have a stroke to get through triage? 10 minutes. How long does it take until the first provider logs in? 16 minutes. How long does it take to get a CT scan? There's digital dust. When they put that CT order in, we have a time stamp, 18 minutes. Okay, and then how long does it take to get the TPA? 32. So you can track all the processes of care leading to that. And then she stratified each of those by race. And she goes, well, why does it take 5 minutes longer to make it through triage if you're Black in our system? And why does it take 6 minutes longer to see a doctor? And why does it take 13 minutes longer to get a CT? So are we surprised if you fall that far behind that you get a 20-minute delay in care? She was able to identify that gap on day one. So when Dr. Cui talks about speed and tact time, and Dr. Shippey is talking about improvement science, we've accelerated speed of insight by 10,000-fold. What would have taken 6 months to figure out now took her literally 5 minutes. So it's a 10,000-fold increase in speed. But what happens after that is She puts the data up and shows her team, and they managed to close that gap. Within 3 months, they closed that disparity gap, and it remains closed to this day. And that's a rewarding thing. And then just tie back to your beginning, why is it important? Because if you fix equity, you'll fix quality, and the whole system gets better. So I'm just going to leave it there. Thank you.
Fantastic, Dr. Lowe, thank you. And this will now tie into our last question for Kat. I'd like to end with a wide lens view of how the cloud and actionable data can create a closed loop from a social determinants and health equity data perspective when it comes to managing underserved patients with precision. Can you describe what this closed loop looks like, why it is critical, and how these technologies are enabling it in the last few minutes that we have here?
Yeah, and I'm going to invite everyone on the panel to join in here with me, because I know everybody probably has a really great point of view on this. But there's that saying that in healthcare, if it didn't get documented, it didn't happen. And I think what we're starting to see is that there's a lot of great energy and focus on data that is in the system and that's being used, that people are able to take and pull from. But there's really this end-to-end life cycle that we're starting to think about and see our healthcare organizations really pay attention to, that it starts as far as upstream as making sure that the social determinants of health data that you're bringing in is unbiased. And so looking at how AI and predictive modeling is actually able to start to model and clean bias out of data. I know we haven't seen a lot of that, but I would say that's some of the more mature kind of healthcare systems are really taking into account, is the data that we're using for clinical trials biased or unbiased? Is it really including our entire patient population? And then once that happens, it's really getting into more of that, okay, now that the data is in our system and we're unlocking it and we're using it to screen, are we really screening our entire population, or are we leaving certain parts of our population out? Back to that beyond the zip code. And then once we're able to screen and identify who's at risk for social needs or social referrals, then the providers need to be getting that data and they need to be actually applying it. We see them applying it to some of their programs that they're starting to run around social needs. Food security is one of the ones that we're seeing pretty common lately, where now you're able to actually apply that social determinant of health data that is unbiased, and you're able to actually write prescriptions for it: food, housing, transportation. And those referrals are going out into the community, and you're able to actually track in the community what's being filled around those prescriptions. And then the ultimate goal is to make sure that that's getting back into the health systems to show how social determinants of health in a very precise way is actually moving the needle on clinical outcomes that matter to those organizations. We see diabetes, we see hypertension, we see CHF as examples of that, where how did we, by using our social determinants of health data or social data, start to actually help our patients, the one and the many, self-manage their diabetes, either because we identified a food insecurity, or they were able to recover from their amputation because they actually were able to get housing through us and our community partners. So I think to think about this idea that social determinants of health data has an end-to-end life cycle, and closing the loop is really what it's in service of the whole way through. And then I would say I'd end with also measuring, right? So metrics. There are no metrics that really exist around this. And so we're helping organizations really think about what are the metrics that matter to them along that journey, that end-to-end journey. And that's where data is helping to get really precise around measuring the impact of using that social determinant of health data. And that to me is where it gets really exciting and really, really complicated. So it's really nice to have, to hear these stories happening, at Daptix and Rush, where you're making it come to life. But I think we all know it's pretty hard, but it's so worth it and super exciting things going on. So with that, I'd love to open it up and see if others have this notion of what it means to do a closed loop and how you're doing it or how you're seeing it be done.
Well, I will just say we have Less than 1 minute left. So if someone has a very brief final comment, please feel free to chime in, and then I'll switch over to our contact us slide if any folks want to get in touch with us.
I
want to second that. Absolutely. You got to close the loop. Diagnose the problem, do something, and then is the thing you're doing making it better? If not, do something else. I mean, that is the loop, right? And that is what AWS cloud computing, that enables you to ingest all this data to do that. So you learn faster, which means you can improve faster.
And in that last 15 seconds, I agree. And when you can pinpoint exactly what's needed in those communities that are being served, then you can plan strategically. What else do you need to do to better support them? So whether that's how you need to improve your technology platform, whether it's other resources that need to become available, knowing the data, knowing the community really allows that precise intervention. And that's ultimately the goal.
Fantastic. Thank you so much to a wonderful panel and a great discussion. I think we'll advance ahead to our contact slide now. Thanks so much for your time to everyone in the audience. If anyone has questions for the panel or would like to get in touch with us, feel free to take a screenshot of this slide and follow up with us directly. Enjoy the rest of the sessions, and thanks to all of our panelists.
Thank you, Alex. Thanks, everyone.
Thank you.
Thank you to our speakers for that wonderful discussion. We'd like to once again thank the sponsor of this session, Amazon Web Services. For more information about them, please visit aws.amazon.com/health. Enjoy the rest of the event.